Welcome back, everybody. I hope you had a great day yesterday. We had some fantastic workforce discussions. And today we're going to talk about innovation, equity, automation, security, basically everything else, all the stuff that has to be done with the workforce that we talked about yesterday. We have a jam-packed day, so I want to remind you to stay with us throughout the day. Chat during the conversations to ask questions, and of course, come camera ready to our roundtable from 5 to 6 p.m. Eastern. We want to thank our sponsors, T-Base Communications, RevShare, Walters Kluwer, Guidehouse, Automation Anywhere, and SADA Systems. We really have a special keynote this morning. Let me welcome Dr. Peter Poullos. And Peter has done some fantastic work in the area of physician engagement of all kinds. And when we think about engagement, we're almost always talking about patients, but Peter's going to talk to us about how do you get physicians of all kinds of different capabilities to be able to engage properly in our health systems. All right, welcome back, Health Impact audience. We've got a really great keynote topic that we're going to pick up here. There's a lot of discussion in the industry going on about combating health inequities. We're trying to figure out how do we improve care for all patients, but we know that a good chunk of patients have a number of disabilities. Whether you're, if you think about healthcare and we say that, well, you've been diagnosed with diabetes, or you've been diagnosed with congestive heart failure, been diagnosed with cancer, we kind of treat you in that specialty, but we don't really do that with patients with disabilities. We kind of like push them on to the side and say, well, that's a different class of problems than their healthcare problems. But that's not quite the case. And that's why I'm really excited here to talk to Peter today about this topic, because it's really hard to discuss it. There are problems in how we introduce these topics. There are problems in how we identify people with disabilities, all kinds of different ways. So we're going to spend a little time with Peter here talking about how the heck do we just talk about this topic, and then really move into the idea, is there anything we can do with inclusive innovation, universal design, and those areas to actually make a difference in people's lives, especially in those cases when they need a little bit more attention from technology, such as when they have disabilities. So with that, Peter, please introduce yourself. Tell us a little bit about who you are and what you're doing.
Yeah, hi. Thanks for having me today. So my name is Pete Poullos. I am a clinical associate professor of radiology at Stanford University. I graduated from med school in 1999 and started my internship in internal medicine at UC San Francisco that year. Finished the residency and started a gastroenterology fellowship in 2002. But 6 months into that, I had an accident and suffered a spinal cord injury at the level of C3, C4. I was initially paralyzed from the neck down completely, but thankfully recovered enough function to be able to walk again and use my arms for computer work and whatnot. So, I mean, I still have significant disability, but thankfully it was more than I have more function than I started with. So I was sort of faced with a choice after that about whether or not I was going to continue in my current career path, which was very procedurally based, or try to find something that was more in line with my physical abilities. And so I decided to switch into radiology. And so in 2004, I started my radiology residency at Stanford, finished my training in 2009. And then, so now I'm actually a radiologist who deals a lot with gastrointestinal diseases. So it's kind of come full circle. I'm in the same field, but just from a different specialty. Stanford was like really great with my accommodations and inclusion into the department, and sort of thought that Stanford was a very friendly place for people with disabilities. And for a lot of people, it is. But I founded the Stanford Medicine Abilities Coalition in 2018. And once I started gathering a cohort of people with disabilities from the School of Medicine and the hospitals, people started to come to me and share their stories. And we also have conducted surveys and town halls with people with disabilities. And so it became apparent that a lot of people are sort of suffering from lack of accommodations, from stigma, from a pressure to not ask for anything. There's a culture of strength in medicine whereby people are really rewarded for working beyond hard, putting in tons of hours, getting very little sleep. We brag about it, but it's actually kind of alarming, the lack of wellness and balance that we have in medicine. And so for the last 4 years now, I've been working on building a community of people with disabilities here at Stanford, and then also across the country, to really bring people together to promote inclusion of people with disabilities in medicine, both as providers and better inclusion of our patients with disabilities. And so I changed the name from the Abilities Coalition to the Alliance for Disability Inclusion and Equity. And that was a question of language. It was brought up to me by one of our members, Lori Leventhal-Belfer. She's a psychologist, and she pointed out that using the word abilities instead of disabilities is like using a euphemism, avoiding the term disability, like as if it were something to be ashamed of or something to be avoided. Whereas we're trying to take the approach that no, disability is something to be sought after and celebrated. And so we wanted to include the word disability in our name. And there are a host of other euphemisms that, language is very interesting around disability. We don't like people saying differently abled or handicapable or differently abled, things like that. I think I said differently abled twice, but these are sort of outdated terms, like handicapped or crippled even. And so yeah, we really wanted to put disability front and center in our name and show that we're actually proud of the position we hold as healthcare providers and as patients.
Perfect. And what is the biggest challenge, Peter, of getting inclusion for disabled people, especially on the care provider side? Is it awareness, or is it something more than that?
The inclusion of healthcare providers with disabilities? Mm-hmm. Yeah, so it's complicated. I think the number one factor is stigma, that people are afraid to disclose their disabilities because they feel like if people know about it, that they'll look down on them, that it'll affect their performance evaluations, that it will derail their careers. And so rather than asking for the accommodations that would enable them to work in an equitable fashion with non-disabled people, they try to just tough it out. There's a lot of, I think a lot of the so-called weeding out happens before people even enter the field. I mean, they look at the lives of doctors and this superhero stereotype of the physician who can do everything, and they just think to themselves, like, there's no way I could hack it, not realizing that there is a place in medicine for people with disabilities, and in a lot of different specialties. There are a lot of specialties that don't really require the use of your arms and legs, radiology, pathology, psychiatry are the ones that pop to mind, but also any of the non-surgical fields, especially with accommodations. And so I think that there is also like a lack of visibility of doctors with disabilities, that there's a lot of people out there who aren't aware that they're not alone. And so, we've been trying to create a community. We've had national conferences on disability to bring people together to have these conversations. We have a mentorship group for students and doctors with disabilities from all over the country. And, people have said that, before this group came along, they thought that they were the only one, and now they have a community, and it motivates people to, to continue in their careers. A lot of people consider dropping out. But a couple of people have told us actually that if it weren't for the mentorship group, they would have left medicine. So that's been really gratifying. So those are two of the issues: stigma, weeding out, the culture of strength. There's a lot of people in medicine who feel like there isn't room for people with disabilities, that they buy into the stereotype, and in some respects, it's an uphill battle.
So when you think about the organizations that properly look at the diversity of their clinical staff, especially when it comes to disabilities, do you feel like if an organization is not actively trying to hire or be more inclusive towards clinicians, whether it's doctors or nurses or administrative staff, et cetera, that have disabilities, do you feel like those organizations cannot possibly serve patients with disabilities if they can't even be inclusive for physicians? Or is there a way to say, no, your ability to take care of disabled patients has really little or nothing to do with how you hire or your staffing at your organization with respect to the clinicians? That's a provocative statement, but I'd love for you to.
No, I mean, a lot of people feel that way. Like, we don't need people with disabilities to tell us how to take care of disabled patients. We know how to do it.
Right.
It's not that hard. We learned it in medical school. But what we've learned, and I think what we're seeing now, is that all of these diversity efforts have to be deliberate. The status quo is the path of least resistance. And so, you can say, yeah, we want diversity. We have a goal of, say, for example, having a 30% diverse population in Stanford Medicine. One of our goals, our Commission on Justice and Equity, said by 2030, we want 30% of the organization to be from underrepresented groups, right? But like, how do you get there? And it has to be deliberate. You have to go out and find people. And there are lots of different ways of doing that, but it has to be deliberate. And the same thing on the patient side. If you don't attack things in a deliberate fashion, you're not going to achieve anything. And one of the big problems is the lack of information we have about our patients with disabilities. Some of this disability information is often not captured in the electronic health record. And so, we don't even know how many patients with disabilities we have. Now, I mean, the definition of disability is quite broad. It's basically anything, any impairment that has a negative impact on your life. I mean, to paraphrase the Americans with Disabilities Act, if you have an impairment and it negatively affects your life, that counts as a disability. But we don't necessarily think of some of our patients with disabilities as disabled. And sometimes the people with disabilities themselves don't even know that their condition qualifies as a disability. When people think about disabled, they think about people who use wheelchairs or those with blind or visual impairments or deaf or hard of hearing. but they don't think about all of the other conditions that also qualify. They don't understand their protected status in a way. But
what are some examples of the others that are not obvious that you could talk to the audience about?
Well, mental illness is a big one, which is, unfortunately quite prevalent in our population. Anxiety disorders, depression, bipolar, chronic health conditions, inflammatory bowel disease. You mentioned congestive heart failure and diabetes, learning disabilities, dyslexia, ADHD, neurodiversity with autism, Asperger's, et cetera. We take a very broad view, and our alliance actually is open to all of those groups. We're not exclusive to certain types of disabilities. But so anyways, we're not really capturing the data. Bonnie Sweener is a disability researcher from Hopkins, has said, if you're not counted, you don't count. And I think that's true. We're making efforts here at Stanford. There's a program or an initiative called We Ask Because We Care, trying to capture information that's not a standard part necessarily of the medical record about, for example, if someone is a sexual or gender minority, capturing their correct pronouns, capturing more accurate racial data, and also disability status. And so we're working on that. Unfortunately, disability is always the last one. We're sort of an afterthought after people have gone through the race and gender and sexual demographics. Then they think to themselves, who else are we missing? And they either conclude nobody, or they'll think, oh, what about disabled people? And so we're often brought into these efforts, like either at the last moment or even after the initiatives have been designed to rubber stamp them. And it's unfortunate. We were left out of a lot of diversity efforts early on, which was one of the reasons I started the Alliance, just looking around campus at all these great diversity initiatives, which we fully support, but without representation from people with disabilities. And so, we're often an afterthought. Same thing in health disparities. It's been sort of an uphill battle to get disability recognized as a health disparity population. The National Council on Disability, led by Andres Gallegos, is working on that issue at the governmental level. Speaking of which, I think a lot of these issues can only be solved with a top-down approach. We talk about equity and social justice, but we can't also forget that this is the law of the land. Mm-hmm. And we're actually not allowed by law to discriminate against people with disabilities, but yet it still happens. And so, a top-down approach is necessary. Legal approach, using the law and using the power of, leaders, both in the government and of businesses, to mandate inclusion of people with disabilities. But you also need a bottom-up approach in educating frontline supervisors, if we're talking about employees with disabilities, to understand how to properly accommodate or respond to people with disabilities. Because no matter what an organization may have in place at higher levels, and no matter how much they talk about inclusion of people with disabilities, if the frontline supervisors don't understand, then it's very hard to implement. And so that's another thing that we're dealing with here, is that a lot of people are not properly trained on how to deal with staff with disabilities or students with disabilities. And we're now creating training modules on the basics of how to talk about disability, why disability inclusion is important, how to include people with disabilities, sort of best practices. And so that's also very important.
Yeah, and we're about to start a very practical the panel session right after your talk with us here, and they're going to go into a bunch of detail about what can be done with respect to tools, technologies, et cetera, being built. But could you take us in a little bit into that technology realm and say that the last couple of years, of course, we've seen more inequities as opposed to less because of the pandemic, et cetera. Can you share with us, what are you finding with respect to either anecdotal or studies that are showing, is the disparities gap increasing, or is there some reason to believe that the technology that we now have in place because of the last 2 years of a significant investment could make things go easier in the next few years? Is there anything in place that is better than it was before COVID?
Well, I mean, speaking from a personal experience, the ability to do video visits has been absolutely fantastic. Just getting out of the house for people with disabilities can be an effort. Transportation, mobility, there are barriers in doctors' offices with inaccessible equipment. And so the ability to have a visit from home has been fantastic. We're doing a research project right now looking at the effect of video visits and remote technologies on people with disabilities. And we're looking at 5 different patient populations: mobility, autism, dementia, deaf and hard of hearing, and blind people. And so we're just now finishing those interviews and about to do the data analysis. But I would say that your question is a hard one to answer because medicine is so decentralized and every system is different and every disability is different. And so I would say that some institutions are doing it better than others. Some communities, the inequities have increased, and in others, I think things have improved. But again, it's very local. So,
so Peter, the reason why I asked about it that way is that so we saw a huge rise in remote patient monitoring, a huge rise in telehealth, et cetera, and the tooling around it is better. But what I'm afraid of now is that there's pullback. And I love your point of it's got to be top down. So if there's pullback from health insurers, et cetera, from paying for telehealth visits, well, that's going to be a direct impact. And should there be a vociferous pushback from the disabled community, say, guys, no, don't pull back on all this stuff. It has actually helped us out. Be loud and proud about it. And your organization could help with that capability. Because if you don't have CPTs, ICD codes, et cetera, associated with these things, like, for example, back in 2010, we had smoking as a status finally being asked in EHRs. Well, it was important, yet it took us, almost 50 years before we started asking that in an EHR. So from a practical perspective, what can you share with us in a few minutes where you could say, from a top-down perspective, here's what government could do? One, everybody keep paying for more of this technology in remote telehealth, et cetera, because it directly helps the disabled community. We should create CPT codes, ICD codes, requirements in EHRs. What could we do there to help this community?
Yeah, that's an excellent question. I think that, on a local level, just things like having closed captioning in the video visits, the ability to incorporate sign language interpreters.
It's one thing to talk about, but it's a whole other thing to do something about it, right? And so in this case, if we're asking government to do something, what might it be that they can actually accomplish, right? Just putting something through as an act of Congress is really, really hard. But if you had some, really quick suggestions of, like in the EHR, what counters can we put in? could ICD codes and CPT codes be analyzed to give us some of the data that is not being counted today? Like anything that these technologies like closed captioning is already doing, don't pull back on. I think that is something that the community can actually rally around.
Yeah, I think that the technologies are one thing, but it's like that's even a little bit far afield from the practical realities. I mean, right now, the National Council on Disability is just trying to mandate that doctors' offices are accessible to people with mobility disabilities. It's like only 30% of doctors' offices have like exam tables that are that go up and down and are adjustable for people with disabilities. Surveys have shown that the majority of doctors' offices are not equipped to handle patients with disabilities. So, I mean, forget about the technology. It's just on a practical level. If you can't get somebody physically in the door, and I know, video visits can help in that regard, but at some point you have to examine a patient. And doctors are examining patients in wheelchairs, like without putting them on the exam table, without taking their clothes off, without, going through the trouble of doing that. I mean, pregnant women with mobility disabilities aren't even getting weighed in their pregnancies because they don't have accessible scales in these offices. I mean, just basic stuff like that. Or the fact that there's no set curriculum in medical schools to teach people how to take care of patients with disabilities. And the National Council on Disability is working on both of those, creating this national training curriculum, as well as trying to codify a requirement for all doctors' offices to be accessible. And so, so we're talking about two different levels. And I think that, they're both important, but if you don't have like the practical things in place, it's like the technology can only do so much.
No, I think that's perfect advice, because if we don't end up talking about the realities, then a lot of us, like, engineers like myself, will say, well, why don't we just use video visits, and why don't we just use ABC and double down on those? You're like, whoa, hold on a second, because even if you had those, it doesn't actually directly impact those lives in the way that you're thinking about them. And so maybe it's better to say, okay, we care more about education and training. And to me, it seems like one provocative statement we could make as a concluding remark here, because we're about to go into this very nice power panel where we're going to talk about this, is, could we say that if you don't care enough to hire disabled physicians, disabled nurses, disabled admin staff, you can't possibly care about your patients that are disabled? Is that too provocative? Reasonably provocative? Could we start as a statement that we push people towards?
The reality is that a lot of the people doing the research on patients with disabilities are providers with disabilities. And this has been shown, over and over, that the people who are most likely to do disparities research are the people who are, members of that population. It's not that other people don't care, but, many people researching, for example, inequities in the African-American population are African Americans. And so that sort of representation is important in that way. I would say, like, on the other end of it, like sometimes initiatives are begun, or research is begun, without input from the actual population that's being studied. And so, especially in academics, we tend to do things in a vacuum, and then create, for example, some project or solution or research project without actually asking the people in that population what they think, getting their buy-in. And this sort of, community-based research really needs to start from the ground up with involvement of those populations. And so I think that's another important point. that we shouldn't be doing any of this in a vacuum, that we should be involving, patients with disabilities. And to that end, we've started a patient family advisory council here at Stanford. We have around 10 patients and 7 or 8 staff, and we meet once a month to talk about accessibility and inclusion of patients with disabilities. And so it's a wonderful partnership that you have people with the actual living the realities of their disabilities, and then you have staff who can actually do something about it. And so that's been really satisfying. I think that those sorts of partnerships are very important.
Yeah, that's exactly right. And so this has definitely been beautiful advice, Peter, especially as it sets up, this keynote sets up our panel that's about to come here. So really appreciate this input. And you could tell just from the conversation how difficult this problem is to solve for a whole bunch of reasons. And so from a rallying cry or a call to action, any information you can give about your Stanford organization, what website can they visit, et cetera, so that they can become part of this movement that can help open up some of these discussions?
Sure, yeah. So, we changed our name recently. So I think the website is still our old name, med.stanford.edu/SMAC. But hopefully they've linked the SMADIE to it. But anyways, if you search Stanford Medicine Alliance for Disability Inclusion and Equity, that'll pop up. I would say that we have videos on our website from prior conferences talking about these issues. And we actually have a conference coming up on April 23rd featuring Alice Wong, who's a very powerful disabilities advocate, and Andres Gallegos, who I was talking about, the chairman of the National Council on Disability, as well as some other really dynamic speakers. And I think that, that would be a good way for people to start learning about it. They can message us on our website or, in the chat at our conference if they want to become more involved.
That's perfect. And we're hoping that many of our audience members will pick up that as a call to action and connect us so that we can actually do some practical things to improve the lives of disabled patients, and maybe start with improving the lives of disabled physicians, nurses, administrative staff, those that are working in the provider community. Well, with that, Peter, I really appreciate you spending this time with us on our keynote and leading us to our next panel now.
It was a real pleasure. Thanks for having me.